All right, this is our recorded lecture on chapter 8 and 9 combined, 8 on the appendicular skeleton, specifically the upper extremities, and 9 on the articulations of the upper extremities. So we'll start here with a review of the appendicular skeleton. As you recall, it's composed of bones of the upper and lower limbs, including the pelvic girdle, and which we talked about in Module 1, and now the pectoral girdle, which we're going to be emphasizing here, along with the upper limb. Here are some examples of some articulations that we'll also be talking about in the upper limb. The glenohumeral joint, which is the shoulder joint, the humeroradial and humeroulnar joints, which form the elbow joint, and the proximal and distal radioulnar joints are just examples. But you are familiar with just sort of the lay terms: shoulder joint, elbow joint, wrist joint. Those are all part of the upper limb. So we're looking at sort of the faded out area now for the appendicular skeleton. And as you recall, the sternoclavicular joint allows the connection between the pectoral girdle and upper limb to the axial skeleton. It is the only articulation here where the upper limb is connected to the axial skeleton. And so, as we've talked about before, that lends a large degree of mobility to the upper limb. These are just some of, this is the diagram in chapter 9 that shows the anatomical names of joints, which you need to be familiar with, as well as how to structurally classify all of these joints, as well as functionally classify them. So we'll be reviewing these as we come to them in the lecture here. But there's a diagram posted to Blackboard that is an unlabeled diagram that's helpful for practicing labeling these, as well as all the information that you need to know about those joints. As a reminder, remember, we're looking at the most mobile joint in the body here to start with, or early in the discussion of joints of the upper limb, the glenohumeral joint. So as a result, it has very low stability and is therefore having to be stabilized by all these different ligaments that you can see in the diagram here, as well as several tendons of muscles that we'll talk about. And then as we move up from left to right, we're moving into less mobility but more stable joints. And so we have talked already about the intervertebral joints between the discs here being amphiarthroses, whereas over here we're going to have a synarthrosis with the joints in between the cranial bones. And we'll talk more about those joints in Module 3. So we'll start with the pectoral girdle, which is made up of the scapula and the clavicle. Again, the pectoral girdle is part of the appendicular skeleton, not the axial. And just some highlights of the scapula. We're looking at the anterior view of the scapula. So it has this large, semi-depressed area called the subscapular fossa. And again, this is the anterior side that lies against the surface of the ribs. We can see that the bone has 3 sides and 3 angles, and so we'll be naming those in lab. And a couple of important processes, the acromion and the coracoid process. The acromion is going to be important here to articulate with the acromial end of the clavicle. And then here our glenoid cavity or glenoid fossa articulates with the humerus to form the shoulder joint. On the clavicle, we can see there's a sternal end that's going to articulate with the sternum at the sternoclavicular joint. And again, that acromial end that articulates with the acromion at the acromial clavicular joint. This is the superior surface. This is an S-shaped bone from the superior view, and here's the inferior view of it. In the inferior view, we can see this structure here, the conoid tubercle, which we'll also talk about in lab. All right. It'll be important to figure out whether you're looking at a right or a left clavicle based on some of those characteristics. Here we're looking at how the clavicle and scapula articulate at the acromioclavicular joint. And this is a planar synovial joint. That's how we would structurally classify it, as synovial planar. And as a synovial joint, we would functionally classify it as a diarthrosis. It does have a number of ligaments that help stabilize that joint as well. We can also see, the photographic atlas-like image here of not only the clavicle but the scapula here as well. Now, the sternoclavicular joint, again, is where the clavicle articulates with the sternum to connect the pectoral girdle to the axial skeleton. And so we're looking at that sternoclavicular joint here. You can see the surfaces are slightly concave and convex on both surfaces, articular surfaces of the bone, with an articular disc in the middle, and that creates a saddle joint. We only have two synovial saddle joints that we talk about in the human body. The other we'll talk about in the hand today, but it is similar to a condyloid joint in terms of its planes of mobility, as we'll see. Well, with the pectoral girdle, we can elevate and depress the pectoral girdle, which we usually refer to as elevating and depressing the scapula. And we can also protract, which means moving the scapula forward, and retract the scapula, which is moving it back towards the vertebral column. And so it's really the whole pectoral girdle that's performing these actions, primarily from this joint here, because it is a saddle joint. We can see a number of ligaments that help support that joint as well. All right, so now we're looking at the humerus and how it articulates, the part that articulates with the scapula or pectoral girdle, which is the head of the humerus. You can see the articular cartilage there. And this is a good place to refer to some terminology that we'll be talking about in Chapter 6 on the anatomy of a long bone. The humerus is an example of a long bone where there is an epiphysis at the proximal end as well as at the distal end, and a diaphysis right along the shaft here. So the head is at the proximal epiphysis, then the anatomical neck is here, the surgical neck. There is a deltoid tuberosity coming down the lateral side that we'll see right there, where the deltoid muscle inserts. And down at the distal end, we have several features that articulate with the radius and the ulna, particularly the capitulum and the trochlea. And we have some depressions just proximal to those parts here, where parts of the radius and ulna will sort of slide into when we flex the elbow joint. So proximal to the capitulum is the radial fossa, where the head of the radius slides in. Proximal to the trochlea is the coronoid fossa, where the coronoid process of the ulna will slide in. If we look at the posterior side of the humerus, we can see at that distal end another prominent depression here called the olecranon fossa, which is where the olecranon process of the ulna will slide in here when the elbow joint is actually extended. So these depressions allow parts of the ulna and the radius to slide in when either the humerus is flexed or when it's extended. All right. Now the glenohumeral joint is an important joint to talk about here. You can see the articular cartilage running along the head of the humerus. We can see the articular cartilage here in the glenoid cavity of the scapula, and then in between is that synovial cavity here where the synovial fluid accumulates. The synovial membrane is in purple here that secretes that synovial fluid. So just a little reminder of our synovial joint anatomy. You can also see a few tendons that help support the joint. The biceps brachii tendon crosses that joint, the long head specifically. The supraspinatus tendon is going to be important for helping stabilize that joint. And we'll talk more about other muscles like the supraspinatus that are in a group called the rotator cuff. And here you can see the deltoid crosses the joint. This is also a good view of that acromioclavicular joint between the clavicle and the acromion, with the articular disc in between, and the acromioclavicular ligament helping to stabilize it. The rotator cuff muscles are important for helping stabilize the shoulder joint because their tendons cross over the joint. So here, where we were looking at that subscapular fossa, we can see the subscapularis muscle, almost like a little preview here for chapter 12, which originates in that fossa and crosses over the joint to insert into the lesser tubercle of the humerus. So by crossing the joint, these tendons help stabilize the joint from the anterior side. We can also see supraspinatus coming across. This is subscapularis, this is supraspinatus coming across the superior portion of the glenohumeral joint and inserting into the greater tubercle. Then from a posterior view, here's supraspinatus once again, supporting that joint superiorly. And then we have these two muscles, and I want you to think of them as sort of partner muscles, the infraspinatus and teres minor. They both insert into the greater tubercle right here, and they act similarly. But anyway, their tendons are coming around the posterior side of the joint to support the joint posteriorly. The one area that we don't see tendons supporting the joint very much here is in the inferior part of the axilla, or the inferior aspect of the glenohumeral joint. And that'll become important when we talk about a particular injury called shoulder dislocation. Another view of the glenohumeral joint now shows the tendons of the supraspinatus, of the infraspinatus tendon here, and of the teres minor muscle here, and subscapularis muscle over here. So you can see from this sort of lateral or sagittal view those tendons and how they support the joint. We can also see a number of ligaments. Well, before we do the ligaments, here's also that biceps brachii tendon, because it crosses that glenohumeral joint to insert into a part of the scapula superior to the glenohumeral joint called the supraglenoid tubercle. We're looking at the glenoid cavity, where there is the articular cartilage in that cavity, in that glenoid cavity, as well as several glenohumeral ligaments kind of lining that cavity here. And we also have a good view of the acromioclavicular joint with supporting ligaments as well. This coracoclavicular ligament between the coracoid process of the scapula and the clavicle is really important for helping stabilize the acromioclavicular joint, as we'll see with another injury. But you can see a number of ligaments here. And I'm just naming them for interest's sake. The coracoacromial ligament here kind of creates this arch that helps support the ligament. And there's another ligament here, the acromioclavicular ligament. Even though it says tendon, it is a ligament. Just notice that. All right, so we move on to the elbow joint, and the elbow joint is formed by two articulations here, the humeroradial joint and the humeroulnar joint. The head of the radius articulates with the capitulum, so you can remember you wear a cap on your head, so the capitulum of the humerus and the head of the radius. And the trochlea here articulates with what's called the trochlear notch of the ulna, which is right in here. When you look at a disarticulated bone, you'll see that a little better. Then let's see, in the posterior view we can see the olecranon process of the ulna and how it articulates with the ulnar, the olecranon fossa of the humerus. The olecranon process of the ulna to the olecranon fossa of the humerus, right in that space there. So this is just a posterior view of both of those joints, the humeroulnar joint, the humeroradial joint. Now, we can only flex and extend that joint, sort of like the hinge of a door, can only open and close the door. So this would be the humeroradial joint and the humeroulnar joints are both classified structurally as synovial hinge joints. And as a synovial joint, we would functionally classify the joint as, hopefully you know by now, a diarthrosis. Now the movement in one plane, like we just saw, there is suggestive that this joint is a uniaxial joint, movement in one plane, flexion and extension only. Whereas the glenohumeral joint, which we didn't mention its actions, can flex, extend, abduct, and adduct, and medial and laterally rotate. So that's a, if you recall, that would be a multi-axial joint. The radius and ulna have a joint between them, two joints, the proximal radioulnar joint and the distal radioulnar joint. The head of the radius here, this sort of side of the cylinder here, articulates with the radial notch of the ulna. And then we have the head of the ulna distally down here. So the head of the ulna articulates with the ulnar notch of the radius. It's almost like a tongue twister. So when we look at the actions at those two joints, supination is when the two forearm bones, the radius and ulna, are in anatomic position, whereas pronation is when we can flip the hand over and you can see that now the two bones cross. So that's pronation, and that's a result of action at the proximal and distal radial ulnar joints. So we'll continue with the forearm in the next recording.